Thank you. And thank you so much to the Pontifical Academy of Sciences, to Lauren and Justin for the kind invitation, to the Bishop for hosting us, and to my new colleagues for the stimulating discussion yesterday. So the first outbreak that I ever investigated sickened 5 babies, turning them blue. The babies were blue because they were starved of oxygen, gasping for air, their lungs suffocated by the bacteria Bordetella pertussis, which causes whooping cough. Worse still, the bacteria had infiltrated their tiny lungs when the babies were already patients inside a hospital. They were infected, my investigation discovered, while cocooned inside plastic incubators in an Arizona hospital's neonatal intensive care unit. They were patients there for heart surgery and other complications of premature birth. The hospital should really have been a safe haven for these babies. Arguably, they were the most vulnerable patients in the whole hospital. Instead, they had been infected there. But how? It was my job to solve the mystery. This was 10 years ago. I was newly arrived in the United States from England to serve as an officer in the US government's Epidemic Intelligence Service, a group of doctors and scientists deployed to investigate epidemics and stop contagion. It was my dream job, but I soon discovered that the work of a field epidemiologist, also known as a disease detective, was not glamorous. Inside the hospital, I unfurled a tape measure to track the distance between the baby's incubators in the NICU. Could one preemie have coughed hard enough to spread bacteria to another preemie 4 feet away? Probably not, I thought. I studied the pages and pages of the hospital's visitors log. I interviewed the parents of the babies, grilled the families on their health. Did you visit the NICU when you were sick? Did you cough on the babies? Did you bring in their siblings, perhaps little toddlers who were also sick? It turned out the parents were fine, their other kids were fine. All roads in my epidemiological investigation led to a far more disturbing smoking gun. The babies were infected in the neonatal intensive care unit by neonatal intensive care unit healthcare workers. 15 of them. 15 healthcare workers looking after the babies in the NICU had whooping cough and attended work while sick. Even worse to me was that these healthcare workers who coughed on the babies, many of them were not vaccinated against whooping cough and did not want to be vaccinated against whooping cough while working in a NICU with tiny babies. As a consequence, 5 babies nearly died from a disease that can be prevented by a safe and effective vaccine that we've been using for decades. And so my first years as a disease detective at the United States CDC brought me face to faces with diseases that I thought were medieval. Measles, mumps, whooping cough. As a medical student in England, as a doctor in London, I had never in my life seen the rash of measles on a real person. I had to study the rash of measles in a textbook. I had never heard the characteristic whoop of whooping cough in a real person. My professors in med school made us listen to old audio recordings of whooping cough that were recorded before we were born. So I arrived in America for my dream job as a disease detective, fully expecting that I would be chasing exotic, novel, emerging pathogens. There was some of that, but the bane of my life, the bulk of my day-to-day work, was investigating outbreaks of diseases that were not new. They were old. They had been banished with the advent of vaccines, and yet they were re-emerging because people were choosing to not get vaccinated and to not vaccinate their children. I felt so useless. My medical training, even my scientific training, which in the early 2000s involved months and months of plating coronaviruses, funnily enough, to see how these fascinating viruses mutated, had not prepared me for this challenge. And I felt so frustrated. In the midst of these horrific outbreaks across the US, where where school after school closed because of mumps outbreaks. And my supervisor at one point even asked me to investigate parents who were making their children who were sick with chickenpox lick dozens of lollipops so that the parents could mail out these chickenpox coated lollipops, which is a federal crime, by the way, to infect other children so that the kids wouldn't have to get vaccinated but would get chickenpox from the lollipops. I mean, I was doing such bizarre investigations. I was so frustrated and so sad that I turned to yoga teacher training in the evenings, thinking that would soothe my nerves. And maybe if public health was just going to pot, I'd become a yoga teacher instead. Only to hear in the evening, the yoga guru, in the middle of teaching us downward facing dog, warn us that vaccines were toxic and would make us infertile. This is 10 years ago. I wanted to run for the hills. Instead, I ran to Canada to attend journalism school in Toronto. It was a very weird and unexpected career turn after so many years of medical training. But I mean, I was considering yoga as well. But here's how I came to this decision. I was a public health doctor. I was a CDC disease detective. My mandate was to prevent and control the spread of disease around the world. And yet, every time I was deployed to an outbreak, my singular focus, my bosses back in Atlanta would tell me, was the pathogen. You stop the spread of the pathogen, whether it's pertussis, measles, mumps, whatever. And yet, every time I was in the epicenter of an epidemic, I was acutely aware that disease was not the only thing that was spreading. So was information. Health hoaxes were being transmitted from person to person like a virus. There were medical myths, misinformation, disinformation, conspiracy theories. And yet, as a public health doctor, no one had trained me in the science and art of communicating with the public, or the publics, we should say, a term we don't typically use in public health, since we do, unfortunately, frame the public as a monolith. Now, I have to say that I probably have lived in the US for too long, because as a Brit, it's not normal for us to insert ourselves and our personal stories in the discourse in this way, except that my frontline experience of confronting anti-science and especially anti-vaccine sentiments from even among my fellow healthcare workers, my firsthand experience of facing medical distrust from patients, and my experiences contending with the spread of messaging that was unraveling decades of advancements in public health is really a critical part of my journey and a big motivator of the work that I do now, which I'll get into in a moment. And in fact, before I get to that, I do actually have to share one more piece of personal information with you. And it's personal information from when I was a girl. It predates me going to medical school, even wanting to be a doctor. So my family is deeply Muslim, very devout, immigrant family from India, arrived in the UK in the 60s and 70s. And we live in the Midlands, literally in the middle of England. And my generation was born there. So we're British born and raised, and we were raised to be conspiracy theorists. So I was a conspiracy theorist growing up. I can share details over coffee about the very strange things that we believed in, or you can read them in my book, because now as somebody who debunks false information about health and science, as I was writing my book, Viral BS, Medical Myths and Why We Fall for Them, I thought I really have to start the introduction chapter with a confession that I was raised this way. I believed really weird and wacky things. But our belief in conspiracy theories as kids, as a community, it wasn't just my family, it felt like a form of survival. It was a way of understanding a world that was harsh, unwelcoming, and sometimes incomprehensible. And you know, my book, Viral BS, tracks different bizarre medical myths. People want to eat their placentas after they give birth, thinking it will cure postpartum depression. It doesn't, and the book goes into that and other myths. But there's chapter after chapter of things that sound like they could not be true. Governments experimenting on disabled children, you know, governments purposefully infecting people, prisoners, commercial sex workers with sexually transmitted infections to see what the infection would do. It does not sound like it's believable, and yet it happened. So when in 2013, I began to track and study the development, evolution, and spread of anti-science and specifically anti-vaccine messaging, mostly in the US, it made sense to me that people could believe that vaccination programs were part of a government conspiracy to track populations or even to cause harm in minoritized people. I didn't have to develop empathy to understand that. It made sense to me in the context of a British Muslim who grew up hearing stories of partition, Britain's horrific history in India. You know, we grew up hearing these stories about our family escaping this, and we knew that governments really were capable of acts as heinous as genocide against innocent people. So why then would we believe governments when they demanded that we inject unpronounceable chemicals into our bodies? And yet I do inject multisyllabic chemicals into my body and my patients' bodies because I have the privilege of an education that allows me to analyze a randomized control trial for its power, for its statistical significance. Most of my family didn't go to university, doesn't have this educational or professional privilege. And many of my patients, the populations I've cared for, do not possess these privileges. So it was this, alongside my frustration that public health had relegated communication with the public, had relegated engagement with the public to an afterthought. Oh, communication with the public it's something we do once the real science is done, once the hard science is done. When we have a vaccine, oh, then we'll figure out how to convince people to take it. It was that frustration that led me to journalism school and to my current work as director of the Stanford Health Communication Initiative, where we study health communication. We train scientists and healthcare workers in the science and art of communicating science, because there is a science to it, there's evidence to it. We talked yesterday about the need for publics to engage with deliberative processes, for the need for the public to take on that work of developing and deploying critical thinking and media literacy skills, and I'll come back to that. But what we are asking scientists and healthcare workers to do right now, in the midst of a public health crisis that is already escalating rates of burnout, is to take on the work of being expert communicators, of being professional debunkers, skills that we are not routinely taught unless we take that on top of our clinical work, on top of our lab work. And, you know, in the clinic, in the lab, we practice evidence-based medicine. And when it comes to communication, we do not practice evidence-based communication. We turn to archaic models like the knowledge deficit model, whose own deficits in permeating biases and shifting beliefs and behaviors have been documented by communication scholars for decades, who've been writing in their journals what the deficiencies are for the way that we keep repeating science communication. They tell us we need to harness the power of stories, of narrative, but narrative scares scientists. Despite the evidence about the cognitive power of stories, to us, a story sounds like one anecdote, a single data point. It could be an outlier. We like millions of data points, not realizing that there's not a story in that doesn't resonate with our audiences. I now do teach science communication and public health storytelling to CDC scientists. And the fact that I'm invited by the CDC to do so speaks volumes about the shift in culture at the agency in the almost decade since I worked there. Because when I was there, that was not our way of, we weren't into storytelling. It was very dry, very scientific. So the change, the culture shift is happening a little bit in terms of our changing the way that we communicate and engage with the public, but it's bittersweet because for people like me and other scholars, we've been trying to convince public health agencies for years that the spread of misinformation and disinformation is a threat to national security. It threatens to unravel achievements made through public health, such as with vaccines. I now sit on a committee of the National Academy of Sciences, Engineering, and Medicine in the US, specifically framing the spread of misinformation and disinformation about science as a threat to national security in the US. So finally, I feel like that's being acknowledged, but it's taken this to get here. My research now lives at the intersections of epidemiology, medicine, and journalism, and investigates information equity as a social determinant of health, much like how your proximity to a beautiful park or green spaces impacts your well-being, or whether you live near a gym, you live near a library, you live near a chemical factory or a jail, impacts your health. So does your access to high-speed broadband internet. So does the local news infrastructure in your town, city, or village. So straight out of journalism school, I was recruited to work as a science reporter at the Dallas Morning News, a Texan newspaper which was founded by a Brit in 1885. It was not a job that I ever expected to do, but it was one that I deeply appreciated and respected, given my frontline experiences of what happens to people and communities when they lack access to credible, relatable news about health and science. And yesterday, towards the end of the day, the bishop asked us to consider and present solutions. So here's my solution for us to consider. A solution that I believe can counter the spread of misinformation and disinformation, an antidote potentially to the spread of anti-science messaging and distrust in medicine. The solution, the possible solution that I want to present is to invest in robust local news infrastructure. Now, I will be the first to criticize and critique Western media as historically and even currently institutionally racist, Islamophobic, and even with sometimes waning trust in the media now among some communities, for often legitimate reasons. Here's why I still think that local news can be a possible solution to the challenges that we are talking about. Local news can serve as the immune system of a democracy. Because let me tell you what happens when a town or a city loses its local newspaper. Taxes increase by an average of $85 per person. Government costs increase and government corruption increases. Elected officials are more likely to conduct themselves with less integrity and less efficiency. The bond terms for loans that a town or city takes out worsen when it loses its local newspaper. Voter turnout decreases. Fewer candidates run for political office in a place that lacks a local newspaper. So local news at its best, at its strongest, can facilitate depolarization and advance social cohesion. Where local newspapers are lacking, we call these places news deserts. We really should call them newspaper deserts because the existing research, it's still in its nascent stages, really looks at places that have lost local newspapers, not so much looking at local radio, which can be fantastic, even local TV news, which in some places is really, really solid in the US. Where many more Americans now live in a news desert than 20 years ago. Around 2,000 Americans, newspapers shut down between 2004 and 2018, leaving more than 1,000 communities across the US without access to accurate news. And the people worst hit by the loss of local print news, you won't be surprised, were mostly poor, mostly people of color, people living in lower income and rural neighborhoods. And over the last 18 months, maybe over the last 2 years or so, we've talked in the pandemic about disparities in morbidity and mortality when it comes to COVID, how Indigenous people in many parts of the world are more likely to get sick with COVID than their white neighbors, for example, more likely to travel much, much farther to see a doctor or a nurse. We talked in the US at one point about how Black Americans living in Kansas were 7 times more likely to die from COVID than their white neighbors. But we've talked less about disparities in access to information about health, about science. We've talked less about information equity or information inequity, about how access to information is a social determinant of health, as important perhaps as your ability to access a nurse or a pharmacist. Our research, we think, is the first of its kind to look at information inequity in combination with health deserts, areas where people face significant barriers to getting medical care. So we're mapping the United States, we're co-analyzing data sets on access to healthcare. So we're looking at which parts of the US are medical deserts, who lives there. Now let's look at which parts of the US constitute news deserts, broadband internet deserts, vaccination deserts. And our preliminary analyses do show some correlation between low vaccination uptake and places that are news deserts, perhaps because people are exposed to so much false information on social media about vaccines, and then they don't have that robust local news infrastructure where their credible local journalists are telling them, actually, no, what you're seeing on Facebook in a closed group is inaccurate. Vaccines are safe and effective. They're available for free here. We want to see who lives in these deserts. One of our key questions is, if living in a news desert is bad for governance, if living in a news desert is bad for democracy, then is living in a news desert bad for your health? We want to better map and understand the health information ecosystem, and we want to tailor interventions to the information needs of specific communities. So to end, ever since that outbreak with the 5 blue babies, there were many, many more painful outbreaks after that. But I've been tracking the spread and evolution of anti-science and anti-vaccine messages. And I've seen how these messages are about so much more than what is inside the vial. It's not just about the chemical makeup of the vaccine. Yes, there are still the Andrew Wakefield-inspired lies about vaccines and autism, vaccines and toxicity. But what I also see and what I still hear are these messages that say vaccines are in opposition to the American way of life. To get vaccinated is anti-freedom and therefore it's anti-American. That's what we're up against. And right now, I don't think public health is well equipped to counter those kinds of messages. The issue of science literacy is also not new, so I'll end with this. I don't think it's enough to ask people to believe in science, just believe in science. I'm sure everyone at this table is far too sophisticated to do that, but a lot of scientists and commentators, and I think myself working for CNN, I'm sure I've gotten so frustrated in the last 18 months that I've said, just listen to the science and get vaccinated. But I'll just share that there's a study published this July by Alexandra Heyman Nash at the University of Pennsylvania that found that study participants who expressed believing in science were more likely to fall for false science and more likely to share pseudoscience than those people who said, no, I'm a skeptic, I don't believe what the scientists say. I'll end with one thing that is a little bit hopeful. We talked also, about different solutions, and we talked a lot yesterday about starting the media literacy, digital literacy, and critical thinking with younger people. So I am writing a book for a teenage audience called WTF, What the Fact? Which teaches critical thinking, because otherwise I think we're just overwhelming young people with this idea, oh, there's fake news. I mean, I don't like that term, but there's so much fake news out there. And then what? What skills do we want them to have? The social media lab at Stanford, led by Jeff Hancock, actually their analyses found only 0.15% of news out there is actually fake news, if you want to use that term. But research by scholars at Nanyang Technological University in Singapore found that when you tell the public there's some fake news out there, many will say it's all fake. Okay. I'll end it there. So just to say that we need a populace that can assess reporting and assess information critically, and that I believe that robust local news can be an antidote. Thank you.
Thank you.